Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and avoid the collapsing U.S. healthcare system. I was pleasantly surprised actually to see the response I got from one of the recent videos I did on testosterone and depression. I wasn't expecting much interest in that topic, even though I think it's actually really important. But compared to my other videos, man, that one really took off. So because of that, I want to talk with you guys a little bit more about depression. This time, not in the context necessarily of how testosterone can benefit depression, but how thyroid hormone can benefit depression. And this is something that I've known about, or I have heard about, going back many, many years. But unlike testosterone, I'll say up front that I've never actually tried this personally with a patient. So the use of thyroid hormone in the treatment of depression, while it's, relatively, I won't say it's common, it's much much better understood within the psychiatry world, hasn't, in my opinion, or at least from what I've seen, made its way over into like mainstream primary care, at least not yet. But as I'm going to show you guys, there is a copious amount of data showing that thyroid hormone, specifically T3, but in some cases also T4, can actually have a potentially profound effect on improving depression, in particular in patients that are already on an antidepressant but maybe are not getting adequate control of their symptoms. So as I'm going to show you guys, I think the data supports using T3 in particular, but possibly T4, as a perfectly reasonable adjunct in a patient. For example, if you're suffering from depression and you're on a good dose of Zoloft, if you're not getting adequate symptom control, typically the response, from your doctor and your psychiatrist will be the addition of a second antidepressant, perhaps one that works in a different way. So, back in my primary care days, we used a lot of SSRIs, and then in patients who had inadequate responses or potentially had side effects with higher doses of SSRIs, many times we would prescribe them Wellbutrin, because that seemed to work well as a combination. But as I'm going to show you with this data, I think it's perfectly reasonable to not necessarily add a second antidepressant, but to consider the addition of thyroid hormone into your regimen just for the purposes of controlling your depression a bit better. This is not something, like I said, that's commonly done in primary care, but there's a strong enough literature base going back many, many, many decades that I think it would be not unreasonable to potentially have this discussion with your psychiatrist or with your primary care physician, and maybe show them some of this data to see if it's something that they would consider doing for you, because all the literature out there says not only that it works, but it's actually quite safe. And it's not just for people that have documented low thyroid. All of these studies I'm going to show you are in people that had perfectly normal thyroid function, yet they still benefited from additional, in many cases, super physiologic thyroid hormone levels, and they had minimal to no side effects, which is very hard to say that about antidepressants. Almost all antidepressants will have side effects to one extent or another. So with that said, let's get into this a little bit. So I mentioned that the use of thyroid hormone to treat depression goes way, way back. This is an article from 1958, the application of triiodothyronine, which is T3, in the treatment of mental disorders. And specifically, they were talking about depression. Now, in this case, they were talking about monotherapy with T3. So they weren't actually using an antidepressant. It was just thyroid hormone. In this particular study, it went through a bunch of different cases. So keep in mind, this is from 1958, so the quality of the data back then was clearly not, let's just say the standards were not quite as rigorous. So I don't think there's enough data out there to say that T3 alone, or T4, or even a combo of T3, T4, is necessarily going to be first line for treatment of depression. But as I'm going to show you later, it certainly is second line when you add it to an SSRI or another antidepressant that's in the mix. But I just wanted to show this to you. And actually, I found references even going back like to the 1930s and 40s, with the use of thyroid hormone to treat people with, various psychiatric conditions. So this isn't anything that's particularly new. This has been around a long time. It just kind of has gotten lost in the shuffle, I guess. So there's two main ways that you can add thyroid hormone, or two main ways that you can use thyroid hormone to improve the symptoms of depression. The first one is what they call an augmenting dose. So you're augmenting something that's already in place. So this would be somebody, again, I keep using the example of Zoloft, but that is one of the more common ones. But insert your antidepressant of choice in there, and after a certain period of time, this patient is not getting any better, you can augment that medication with the addition of thyroid hormone. And again, it's mainly T3 is where most of the studies are, but again, I'm going to show you one that has T4 in it as well. So you can augment a therapy that's already in place. And then the other way to approach this is an accelerating dose, meaning that you start it at the same time as you start the antidepressant. And I could see a scenario where that would be, probably would be favorable. Most of the time it's going to be augmenting one that's already in place. But if, for example, if you had somebody that was profoundly depressed or perhaps, suicidal, and you need to get them better as quickly as possible, because remember, antidepressants don't work overnight. It can be 4 to 6 weeks before you get a meaningful response. So if you could potentially shorten that response time by adding T3, which you can, according to the literature, with the addition of T3, then that seems like a very reasonable thing to do, in my opinion, especially somebody who is at risk of taking their own life or some other like severe outcome as a result of their depression. So I do want to say though that the studies in here, they're looking at primarily what we call unipolar depression, so not people with bipolar disorder, although I was able to find some studies showing that it did help in bipolar disorder. We're not going to go into that. And it wasn't like really severe depression with, for example, like psychotic features, people that are psychotic. And I didn't see anything in there about like schizophrenia or any of those other things. So we'll just keep it simple. We'll talk about major depression, unipolar, meaning it's not bipolar depression. It's just regular, like run-of-the-mill depression, which, is rampant enough these days. But just keep in mind, there are some studies with other types of mental illness as well, but we'll just focus on depression. Okay. So this first study here, this one caught my eye. This is one of the first studies that I found when I was looking up this subject. So this is from the Archives of General Psychiatry, volume 64. This is from June 2007. It's called Combined Treatment with Sertraline, which is Zoloft, and liothyronine, T3, in major depression. And I will say that one of the main problems with the studies on this subject is none of them are very large. So you're going to get studies with like 15 people, 17, 25, that sort of thing. You're not going to get, 500, which would be nice. Maybe one day we'll get that. But for now, this is one of the limitations in this area, is that we don't have studies with, huge amounts of patients. So this one, they randomized their patient group. So this one at 124 adults. Okay, so for thyroid studies, that's actually really good. Way more than normal. They randomized them to start on sertraline, 50 milligrams a day for a week, and then they bump them up after week 1 to 100 milligrams, which is a totally reasonable dose. The typical ceiling dose is about 200 milligrams. Obviously the higher you go, the more side effects you're going to have, but there typically is not much benefit above 200 milligrams in the majority of cases. So they would get them up to 100 milligrams, and then they would add either T3 at between 20 to 25 micrograms a day, which is not a huge dose. So that was for the first week, sorry. And then they would bump them up to 40 to 50 micrograms a day, which also, that seems to be like kind of the standard dose, up around 50 micrograms a day. Or they would just add in a placebo, and then they kind of saw what would happen. Anyway, long story short, based on this Hamilton rating scale for depression, which is a common way to rate depression symptoms, the patients in the group that got thyroid hormone had about a 70% remission rate, or 70% rate of adequate control, as opposed to about 50% of the patients that just got like sertraline with the placebo. So that's not too bad. There were very few, if any, adverse effects in this at all. So in fact, this says here, there were no significant effects of T3 supplementation on frequency of adverse effects. So that 50 mic dose was extremely well tolerated. Okay, but you can use T4. Now, this is a study, clinical applications of levothyroxine, which is T4, in refractory mood disorders. This is from the journal Clinical Approaches in Bipolar Disorders, 2003. So so what blew me away about this study was the dose. So not surprisingly, like T3, as you guys I'm sure know, is much more potent than T4. T4 typically, needs to be converted into T3, which is then the active hormone. But in this particular case, they used some gigantic doses of T4, and they went up to as high as 600 micrograms a day. Just to give you a reference, I mean, I have commonly, for people with regular old hypothyroidism, you'll see 120, 150 micrograms a day, maybe. Little old ladies, I'd start them off at 50 and work my way up to 80, maybe 100 at the most. But they went up to like 600 mics, like 450 to 600 mics of T4, which is pretty damn generous. But what was interesting about this, and they comment on here, was how surprisingly well people with depression tolerated these huge doses of thyroid hormone. They didn't have, the tachycardia and the tremulousness and the flushing and the palpitations and all the things that you would expect. Now, they did it at some rate, obviously, but way less than what the researchers anticipated. And they said it was, even this 600 mic dose was like extremely well tolerated. So they comment on that here. It says, in studies using supraphysiologic doses of T4, a striking finding was that patients tolerated the high doses of thyroid hormone surprisingly well. Yeah, they totally did. The low rate of side effects contrasts with what typically, this is interesting, with that typically seen in patients with primary thyroid disorder. So like Graves' disease, for example, where you tend to have high circulating thyroid disorders, or in healthy controls treated with higher than replacement doses of T4. So it's just a good reminder that giving thyroid hormone, even if it's in excess, is not really the same as having a primary thyroid disorder like Graves' disease, where you have these autoantibodies that really are the culprit, that wreak havoc in various organ systems. And those two things are not the same. And that's I think that's an important distinction that a lot of clinicians maybe don't quite grasp. So, and then they finish up, they say, despite increased serum thyroid hormone levels, so again, they treated these people, these were supraphysiologic doses, above the normal range, okay? Which just goes to show you that, sometimes you do need to go above, the clinical normal range in order to achieve a certain clinical effect. You can make that argument with testosterone, perhaps, in some cases, but definitely here with thyroid hormone and treating these mood disorders, they were above the reference range, and they, in many cases, suppressed their TSH to undetectable levels, and these patients tolerated it just fine. In fact, they got better. So, despite increased serum thyroid hormone levels, patients with affective disorders reported only minimal side effects. Increased sweating, tremor, pulse, increase in agitation were most commonly reported, and that's what you'd expect with higher than normal thyroid levels. But it wasn't enough to really to cause a huge dropout rate in these studies. No serious adverse events were observed, even after treatment with supraphysiologic doses of T4 over a period of several years. So the serious adverse effects they were looking at were cardiac dysrhythmias obviously would be a big one, myocardial infarctions, strokes, and then also the development of osteoporosis, because that's something you'd be worried about with, hyperthyroidism is osteoporosis, so thinning of the bones. That did not happen, even at these ridiculously high doses. So very interesting stuff. So it's important to recommend, or just to reiterate, high doses of thyroid hormone that are prescribed and ingested, again, that's not the same as having high thyroid hormone circulating levels as a result of something like Graves' disease. Again, those are not the same thing. Okay, here's a couple studies here we'll talk about just to, let's talk a little bit more about safety. This first one here, long-term augmentation with T3 and refractory major depression. This is from Journal of Affective Disorders. This is back from 2009, and these studies, so the average dose of T3 was 80 micrograms, but varied. It was like 25 micrograms all the way up to 150 micrograms, which that's a lot of T3. Average time of treatment was 24.2 months. So these followed these patients for a really, really long time. And again, no adverse cardiac events, no decrease in bone mineral density over that period. They all did really, really well. So that one was with T3. Here's one, bone mineral density in pre- and postmenopausal women with affective disorders treated with long-term L-thyroxine augmentation, Journal of Affective Disorders, 2001. They essentially found the same thing when they looked at bone mineral density. There was no decline in bone mineral density in these women. I shouldn't say there was a decline, but it was comparable to controls, because all women will have their bone mineral density decline, as time goes on, assuming they're not on hormones or, some other form of treatment if they're postmenopausal. So this is a safe approach according to the literature. Even these really even doses that make me nervous seem to be extremely well tolerated in people with depression and don't have all the things that I learned about in medical school, it doesn't appear to precipitate atrial fibrillation or cardiac arrest, or it doesn't turn people's bones to chalk, and all the stuff that I was taught with Graves' disease and other hyperthyroid conditions just doesn't seem to be happening with the addition of thyroid hormone. So for those of you maybe that are in the clinical world and maybe are interested in prescribing this, or those of you that want to maybe show this to your doctor, this is a sample guideline for how to use T3, and it comes from this article here, T3 augmentation in major depressive disorders, in the American Journal of Psychiatry. This is October 2011, and here's a little checklist that they recommend. So they recommend checking thyroid labs, of course, initially. If they're abnormal at baseline, they recommend rechecking labs to rule out laboratory error or transient stressors as causes. Yeah, it's like, if you have an abnormal lab, just keep checking it, man. Eventually it'll get back to normal. I would say you need to work that up, but this is a psychiatric journal, and, no offense to the psychiatrists out there, but many psychiatrists, they don't want to work up medical problems. It's not their area, so they would refer them to an endocrinologist, but, any good primary care physician could work up this thyroid issue. Anyway, they recommend starting with 25 micrograms daily, and then titrate up to 50 mics daily after at least 1 week. Totally reasonable based on the studies that we just went over. So a lot of them were right around that 50 microgram range. And then they say, in an elderly person, maybe starting lower at 12.5 micrograms a day would be a good idea. I agree with that. Little old people, you got to go low and start slow, and then you can work your way up, because they're a little bit sensitive to medication sometimes. But you notice that they're pretty conservative in this particular article. They have you titrate up to 50 mics, but then they don't tell you what to do after that. But it's pretty clear from the other studies that, I showed you there's one there where the T3 dose was up to 150 micrograms. So in my opinion, based on the other research, if you're still not getting a good response at 50, and assuming there are no adverse symptoms related to hyperthyroidism, then I don't see why you couldn't go up again, maybe to 75, and then work your way up maybe in 25 microgram increments, every few weeks. So anyway, recheck thyroid indices at 3 months and then every 6 months. Goal TSH level is at least at the lower limit of the normal range or below in the absence of hyperthyroid symptoms. And that's the most important part with all of this. The dose is whatever the dose is, but clearly you don't want to give your patient hyperthyroid symptoms. And if any of you have ever had hyperthyroid symptoms, I think you could probably relate that that's not a pleasant experience. Okay, being jittery and tachycardic and sweaty and just feeling super anxious, not good. Free T3 levels can be maintained at the upper limit of the normal range based on the severity of depressive symptoms and response to T3. So again, being very conservative, they're saying, oh, just stay to the upper limits of the normal range. But very clearly in some of these other studies, they took a lot of these patients well above the normal reference range, and they all continued to do well. So this is a very conservative approach. And you know what? There's nothing wrong with that. Monitor bone density every 2 years. That's reasonable. We know these studies show at least within 1 to 2 years, there isn't much of a change. But, that just seems like good medicine, good due diligence to do that every 2 years. And then, of course, refer for evaluation of osteoporosis if bone density is declining. This is psychiatrists. They don't want to work up osteoporosis, and I don't blame them. It's not their wheelhouse. So, okay, guys, that's all I got for you guys today. Again, I made this video just for educational purposes for you, just to show you that, that there's a lot of stuff out there that has a really good, or at least really what I consider to be relatively decent literature support that has been around for a very, very long time in the endocrine world for treatment of conditions that are not within the realm of endocrinology. Endocrinologists do not treat depression typically. That's not one of their everyday things. But that doesn't mean that hormones can't be used to treat depression or other conditions that fall outside of the realm of endocrinology. They can be extremely useful. Not related to any of this stuff here, but there's really good studies of using intravenous T3, for example, if you've got a patient who is literally dying of cardiogenic shock, or perhaps they're on a transplant list and everything else has failed. There's actually good studies of using IV thyroid hormone, to try to get a little bit of squeeze out of their failing heart, just to get them, to last long enough, perhaps to get a transplant or an LVAD or, something else like that. So, clearly heart failure is not, especially end stage transplant candidate type heart failure, is not within the realm of what a typical endocrinologist deals with on a daily basis. But again, that doesn't mean that there isn't a reason to prescribe hormones for that particular condition. I personally have never seen that, but you know what? If I was out in this boonies somewhere, and that's all I had, I would do it because there is literature to support it. So anyway, that's why I want just to make you guys aware of this. A lot of people suffer from depression in this country for a lot of different reasons. A lot of people end up on multiple different psychiatric medications, again, many of which have adverse side effects. So, this is something you can talk about to your prescribing physician and consider trying, because there's literature to support it, and it may very well be that you would do better with less side effects on an augmented regimen, for example, with T3, than you would by adding in a second or even a third antidepressant, which I see, quite commonly these days. So anyway, food for thought. I hope you guys enjoy that. If any of you out there have experience with this, please let me know, because I would love to hear from you and have a little discussion about it. I'll catch you guys next time. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.